Good morning, everyone, and welcome. Today is October 20th, 2021, and I'm pleased to call our ACIP meeting to order. I am going to turn it over to Dr. Melinda Wharton to run through our announcements this morning.
Thank you, Dr. Lee. Next slide, please. Good morning and welcome to the October 2021 virtual ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those of you who are participating via the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just no live video. And ACIP voting members will turn on their video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we'll be holding two oral public comment periods. The first oral public comment period will occur today at approximately 3:45 Eastern Time. The second oral public comment period will occur tomorrow at approximately noon Eastern Time. To create a fairer and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket ID CDC 2021-0098. Information on the written public comment process, including as well as information on how to make a comment, can be found on the ACIP meeting website. Next. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. And now I will turn things back to Dr. Lee.
Thank you, Dr. Wharton. I will now take roll call, starting with ACIP members and then our ex officio members and liaisons. And for ACIP members, just remember I'm go out of order and in backwards alphabetical order for now and for future votes or discussions. As a reminder, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. So today, I'm going to start with Dr. Brooks.
Dr. Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporation, no conflicts.
Thank you. Dr. Bell.
Beth Bell, Clinical Professor, Department of Global Health, University of Washington, no conflicts.
Thank you. Ms. Bata.
Lynn Bata, Immunization Clinical Consultant at the Minnesota Department of Health, no conflicts.
Thank you. Dr. Alt.
Kevin Alt. I'm a professor of obstetrics and gynecology at the University of Kansas School of Medicine in Kansas City, Kansas, and I have no conflicts.
Thank you. Dr. Talbot.
Good morning, this is Kip Talbot. I'm at Vanderbilt University Medical Center. I'm an adult infectious disease physician, and I have no conflicts.
Thank you. Dr. Sanchez.
Morning, this is Pablo Sanchez. I'm a neonatologist and pediatric disease specialist at Nationwide Children's Hospital, professor of pediatrics at the Ohio State University. Thank you, and no conflicts.
Thank you, Dr. Sanchez. Dr. Paling.
Good morning. This is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. Thank you.
Did you state if you had any conflicts, Dr. Paling?
I forgot that. My apologies. No, I have no conflicts. Thank you.
Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Long.
Good morning, Sarah Long. I'm a pediatric infectious disease physician and professor of pediatrics at Drexel University College of Medicine in Philadelphia, and I have no conflict.
Thank you. Dr. Lair.
Dr. Jamie Lair, Cayuga Family Medicine in Ithaca, New York, private practice family medicine, and I have no conflict.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I am the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Daly.
Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado's Institute for Health Research, and also an associate professor in the Department of Pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Sineas.
Good morning. I'm Dr. Sybil Sineas. I am an internist and pediatrician, associate professor of medicine and pediatrics at Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Chen.
Wilbur Chen, professor of medicine at the Center for Vaccine Development and Global Health within the University of Maryland School of Medicine, and I have no conflicts of interest.
Thank you, Dr. Chen. And this is Grace Lee. I am Associate Chief Medical Officer at Stanford Children's Health and Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts. So all ACIP members are present. I am going to move on to our ex officio representatives next. Please just indicate if you are present and your first and last name. Centers for Disease Control and Prevention.
Hi, this is Dr. Amanda Cohn, representing CDC today.
Thank you, Dr. Cohn, in a different chair today. Centers for Medicare and Medicaid Services.
Good morning, this is Mary Beth Hance, representing CMS.
Thank you. Food and Drug Administration.
Good morning, Dorn Fink, present.
Thank you, Dr. Fink. Health Resources and Services Administration.
Good morning, this is Mary Rubin, representing Division of Injury Compensation Programs, HRSA.
Thank you, Dr. Rubin. Indian Health Service.
Good morning, Uza Chukuma, representing the Indian Health Service.
Thank you. National Institutes of Health.
Hey, good morning, John Beigel from the National Institute of Allergy and Infectious Disease.
Thank you. And the Office of Infectious Disease and HIV/AIDS Policy. Okay. We'll come back to our OIDP colleague later. Before we move on to the liaison representatives, I wanted to, and hopefully I will get this correct, just acknowledge and recognize that we have had several transitions in 2021 with our liaison representatives, and wanted to recognize and also, appreciate very much the service that three of our colleagues who have been longstanding members of ACIP as liaisons over the past years have provided to the committee. First, I would like to just recognize Dr. Paul McKinney from APTR, who, again, has served for, I believe, decades at this point, and recognize him for his service. He is currently replaced by Dr. Richard Zimmerman. For NACI, Dr. Caroline Quach, who we also did not have the opportunity to recognize the transition to Dr. Shelley Deeks earlier this year. And then I believe today we also wanted to recognize Dr. Stephen Foster, who has served, I understand, for 21 years as the American Pharmacists Association liaison representative to ACIP. And will be replaced by Dr. Hogue, or Michael Hogue. We will now move on to the liaison roll call, but wanted to again thank those members who have served ACIP, and especially over the past year, going above and beyond with the many emergency meetings. And we really appreciate your input, your comments, and your contributions to the discussion over time. So we'll start with the American Academy of Family Physicians.
Good morning. Pamela Rockwell, Professor of Family Medicine at the University of Michigan Medical School, liaison to the American Academy of Family Physicians.
Thank you. American Academy of Pediatrics.
Good morning. Bonnie Maldonado, Professor of Global Health and Infectious Diseases at Stanford University and Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you, Dr. Maldonado. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham in Pediatric Infectious Diseases and editor of the American Academy of Pediatrics Red Book.
Thank you. American Academy of Physician Assistants.
Good morning. Marie-Michelle Léger, representing AAPA.
Morning. American College Health Association.
Good morning, Sharon McMullen, Cornell University, and also my co-chair, Dr. Tavi Chaya, University of North Carolina at Chapel Hill, representing the American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Good morning. It's Dr. Linda Eckert, Professor of Obstetrics and Gynecology at University of Washington in Seattle, and present.
Thank you. American College of Physicians.
Good morning. Jason Goldman, General Internal Medicine and Private Practice, Coral Springs, Florida, Affiliate Associate Professor at Florida Atlantic University. Pleasure to be here representing the American College of Physicians.
Thank you. American Geriatric Society.
Good morning. Ken Schmader for AGS.
Good morning. America's Health Insurance Plans.
Good morning, Dr. Elizabeth Malco, Chief Medical Officer for Florida Blue Medicare, representing AHIP today.
Thank you and welcome. American Immunization Registry Association.
Good morning, Rebecca Coyle and Beth Perilla, representing ERA.
Thank you. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Carol Hayes, representing Dr. Chad Riddle for the American Nurses Association.
Thank you. American Osteopathic Association.
Good morning, Stan Grog, present.
Good morning. American Pharmacists Association.
Good morning. This is Steve Foster, representing the American Pharmacists Association. Dr. Lee, if I may take a moment, it really has been 21 years. I smiled at the last meeting when I was announced that 70% of the COVID vaccinations were administered by pharmacists. When I started ACIP, I was asked to justify how pharmacists were even qualified to give vaccines. Joining us today is Dr. Michael Hogue. He will be taking my place with representing APHA. Dr. Hogue is Dean and Professor of the Loma Linda University School of Pharmacy, but many of you already know Michael because he has been the APHA representative on the ACIP COVID work group. I've enjoyed my time with ACIP. I've had the privilege to meet a lot of wonderful people. I'm looking forward to when we can meet again because I will be coming back to at least set in a different position. Thank you.
Thank you so much again for your service, Dr. Foster. And appreciate the comments. And I can't believe that when you started that pharmacists were not frontline vaccinators to begin with. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Thank you. Association for Prevention Teaching and Research.
Rick Zimmerman, University of Pittsburgh. Present.
Association of State and Territorial Health Officials. We'll move on to Biotechnology Innovation Organization.
Phyllis Arthur, present.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, Idaho State epidemiologist, representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization. Okay, we'll move on to Infectious Disease Society of America.
Carol Baker, University of Texas Health Science Center, Houston, representing IDSA. Good morning.
Good morning. International Society for Travel Medicine.
Elizabeth Barnett, present.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACCHO, present.
National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, representing NAPNEP.
Thank you. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner at Vanderbilt and also Medical Director of the National Foundation for Infectious Diseases.
Thank you. National Medical Association. Okay, we'll come back. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary, representing Pediatric Infectious Diseases Society.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Hi. Good morning. It's Amy Middleman, representing SAM.
Good morning. Society for Healthcare Epidemiology of America.
Good morning. Marcy Dries, Christiana Care, representing SHEA.
Thank you. And if there are any additional ex officio or liaison members who have joined, please feel free to indicate your presence. Okay, with that, we anticipate some of our colleagues will be joining a little bit later. Before we get started, I actually wanted to take a moment to recognize our colleague, Dr. Amanda Cohn, for her incredible service to the CDC and the ACIP as our executive secretary over the past 6 years. And you remember that last meeting I said I would come back to you, Amanda. For those of you, many of you know Amanda well, but Amanda received her medical degree from Emory University and completed her training in pediatrics at the Boston Combined Residency Program before coming to CDC in 2004. And if you'll move to the next slide. And this is where I first met Amanda, when she and I were both in training. And our colleague and former ACIP member, Dr. Hank Bernstein, was one of our clinic attendings. And he actually shared that picture to the left of Amanda during her internship at Boston Children's. We actually have a book that includes messages from ACIP members over the past 6 years, including her former chairs. And I wanted to share some pictures and read a few comments from the book that is due to arrive soon in California, but didn't make it in time for my trip. But I will bring it the next time I come to Atlanta. So here are some quotes from the book, and I won't attribute them, but you'll be able to see the full book in a moment. One person mentions, if you'll go to the next slide, please. Throughout your tenure as Executive Secretary of the ACIP, you have been grace under pressure. Another person states, you have been such a calm hand at the helm, guiding the ACIP and the broader national public health community through so many challenges. Integrity, humility, intellect, trust in the people and the process, these qualities have been your North Star. Another states, you have been a stupendous leader and importantly, a wonderful person. Calm, knowledgeable, and always a guiding light through quite a year. Another person mentions, Amanda has been able to humbly lead people in making a real difference in public policy, especially during these unprecedented times of a pandemic, and this has earmarked you for greatness. Another person states, your efforts now, as well as over the previous years, will safeguard the lives and the health of millions of persons for years to come. And beyond these meetings, you have created a sense of community for all of us. Even during these challenging times, we knew we were all in it together. Next slide. Fond memories include evening meals during the in-person meetings when we were able to get together, gathering for the group photographs on the CDC steps, our lively committee discussions, your serious and concerned face, and the forever engaging Amanda Cohn smile. And I will end on a Dr. Seuss quote that someone actually brought up in the book, which is, "You're off to great places. Today is your day. Your mountain is waiting. Get on your way." In addition to the book that's forthcoming, we actually have a framed picture of the ACIP version of Dr. Seuss for Amanda, and wanted to again thank her for her incredible service and dedication to the ACIP and to our country. We are forever grateful for your time at ACIP, so thank you, Amanda.
Thank you. I'll just say I'm completely overwhelmed. If you could see my face right now, it would be that smile with like super, super redness all over it. But I just, I'm going to miss all of you so much, but I'm not really going that far away. I'm still going to come to all the meetings. And I could not have done this without the support of all the amazing ACIP members, liaison members, ex officios. Like, you guys have been like family to me, and really just amazing mentors. And, you know, I just could not have asked for a better experience at this point in my career. I also have to say we have amazing support staff, and Stephanie and Jessica have been really what secretly keeps this going when I can't. And I know you guys are going to be in such good hands with Melinda, who has also been another mentor to me over my many years, now almost 18 years here. So thank you all. Stay in touch. And y'all are really amazing. Every single time we pull a group of ACIP members together, y'all just, it's amazing every time. And I cannot wait to meet you guys out to dinner sometime in the near future. I hope I'm invited.
All right, thank you so much for giving us the moment to do that. I'm sorry, there's one more slide after this, which is, this is a word cloud that came from all the messages in the book, and I just thought it was such a great example of the wonderful qualities that you exemplify for all of us. So thank you, Amanda. Okay, we will now move on to agency updates. And we will, actually, I'm sorry, apologies, I'll give Amanda a moment, but we are going to go ahead and start with agency updates, and we'll start with the Centers for Disease Control and Prevention.
Thank you. I am going to focus on a couple of non-COVID related ACIP updates as I recover from those kind words. So first of all, I just wanted to let everyone know that the NIS survey, the National Immunization Child Survey for the years 2018 through 2020, which reports on children born in 2017 and 2018, was published on October 15th. This report continued to demonstrate that there was lower coverage among those who were uninsured, Black, Hispanic, and living below the federal poverty line than among those who were privately insured, white, or living above the poverty line, further demonstrating disparities in vaccine coverage, even with our amazing Vaccines for Children program. This report does not highlight what we are seeing over this past year and a half, which is decreased ordering from providers in FY 2020 and FY 2021 compared to FY 2019. So we are seeing some rebounding of routine childhood immunization in the private sector, but we still continue to lag behind, and routine immunization remains a critical part of our full recovery from the pandemic. A short update on influenza. While it's uncertain what's going to happen this influenza season, we are preparing for resumption of seasonal flu virus circulation. And there are concerns that co-circulation of flu, SARS-CoV-2, and other respiratory illnesses like RSV could place a high burden on the healthcare center. So we are raising awareness about the importance of influenza vaccination with our multi-year Fight Flu communications campaign. We're working with the Ad Council, and we're working to increase vaccine uptake overall, with particular emphasis on reaching African American and Hispanic Latinx communities and those at increased risk for severe outcomes for influenza. I also just wanted to highlight the recent call to action by the National Adult Influenza Immunization Summit on August 23rd. This call to action discussed raising vaccine coverage among U.S. adults, of which the focus of our agenda is today. The NAIIS is co-led by CDC, HHS's Office of Infectious Disease, and HIV/AIDS Policy and Immunization Action Coalition. And this highlights the tremendous benefits of vaccines, our low levels of vaccination, which are made worse by the COVID-19 pandemic, and ongoing disparities in immunization adult coverage in the United States. The call to action lists a series of concrete actions healthcare providers can take to improve adult vaccination, and a link to the call to action will be included in the meeting minutes. That's it from the CDC.
Thank you, Dr. Cohn. Next, we'll move to the Centers for Medicare and Medicaid Services.
Thank you. This is Mary Beth Hance, and I have a few updates both on CMS activities around COVID-19 vaccines as well as routine vaccinations. Specific to COVID-19 related activities, we continue to provide materials as there are changes around COVID-19 vaccines. Examples include a press release that we issued in September reflecting the approval of the Pfizer-BioNTech booster doses, and an informational bulletin that we issued in May around the expansion of the Pfizer-BioNTech vaccine to adolescents aged 12 to 15. And we continue to update additional materials such as our toolkits. On August 30th, we released guidance relating to the American Rescue Plan's temporary 100% federal match for state expenditures for COVID-19 vaccines and vaccine administration for those enrolled in the Medicaid and CHIP programs, Children's Health Insurance programs. And on September 9th, CMS and CDC announced that emergency regulations requiring vaccinations for nursing home workers would be expanded to include hospitals, dialysis facilities, ambulatory surgical centers, and home health agencies as a condition for participating in the Medicare and Medicaid programs. In addition, we greatly appreciate the support of our CDC colleagues. They have made many, many presentations to state Medicaid programs and other stakeholders on CDC's COVID-19 vaccination efforts, including efforts to get booster doses to those in congregate settings, efforts to reach adolescents, as well as planning for the vaccination of children aged 5 to 11. In addition, CDC and CMS continue to emphasize the importance of catching up on routine pediatric vaccinations. And again, we greatly appreciate this coordination. Shifting to routine vaccinations, we do continue to emphasize the importance of routine pediatric vaccinations. As Dr. Cohn just mentioned, that is clearly still an important issue. We have an Ensure Kids Now national campaign that has included a number of materials focusing on this that is available to stakeholders, states, grantees, and we are looking for additional opportunities to amplify this message, and we continue to look forward to working with CDC on this as well. Thank you very much.
Thank you, Dr. Hance. We'll move on to the Food and Drug Administration.
Good morning. I'll start off with a non-COVID announcement, which is that last week on October 14th, FDA approved a efficacy supplement to support use of Flucelvax, a quadrivalent cell culture-derived seasonal influenza vaccine for use in infants and children 6 months to less than 2 years of age. This approval was based on a study of safety and immunogenicity of the Flucelvax quadrivalent vaccine in comparison to a U.S. licensed quadrivalent seasonal influenza vaccine comparator that was egg-derived. This now extends the approved use of Flucelvax to all individuals 6 months of age and older. In COVID news, October continues to be an extremely busy month for FDA. On the 14th and 15th last week, we convened our Vaccines and Related Biological Products Advisory Committee to consider 2 emergency use authorization amendments for COVID-19 vaccines. On the first day, the committee heard presentations on data to support a booster dose of the Moderna COVID-19 vaccine for administration to certain individuals at least 6 months after completion of a primary series with the Moderna COVID-19 vaccine. The eligible populations as requested by Moderna are the same as those that FDA authorized last month for use of a Pfizer-BioNTech COVID-19 vaccine booster dose, namely individuals 65 years of age and older, individuals 18 through 64 years of age at increased risk of severe COVID-19 following primary vaccination, and individuals 18 through 64 years of age with frequent occupational or institutional exposure to the SARS-CoV-2 virus. The committee voted unanimously in favor of authorizing this EUA amendment request. There was also some discussion that began on the first day and continued into the second day about whether to lower the age range for use of a booster dose of mRNA COVID vaccines, those being both Pfizer and Moderna, to adult populations less than 65 years of age without additional risk factors for severe COVID disease or exposure to SARS-CoV-2. The committee was mixed in their discussion, with some members opining that a lower age limit should be considered, and others expressing that 65 was the appropriate age cutoff at this time. The committee ultimately opined that FDA should consider lowering the age cutoff as additional data on need for a booster dose emerged. On the second day, the committee heard presentations to support on data to support use of a booster dose of the Janssen COVID-19 vaccine administered at least 2 months after a single dose primary vaccination with the same vaccine to individuals 18 years of age and older. And the committee voted unanimously in favor of FDA authorizing that EUA amendment request. Finally, the committee heard a presentation on data from a study conducted by NIAID regarding safety and immunogenicity of heterologous, or otherwise known as mix and match, booster doses of COVID-19 vaccines, and then engaged in a discussion of these data. The committee members recognized that the study groups were relatively small in number, and that the study was originally designed to be exploratory, but nonetheless, in their discussion, committee members recognized the need for flexibility in implementation of COVID-19 vaccine programs, and and comments provided by committee members were in favor of FDA considering these data to support emergency use authorization of heterologous booster doses to provide a regulatory allowance for mixing and matching. FDA has been very busy since last Friday, wrapping up our review and working toward authorization of these various EUA amendments. We expect to have some announcements later today. Finally, we have also at the same time been reviewing a EUA amendment request from Pfizer BioNTech for use of their COVID-19 vaccine in children 5 through 11 years of age. And we will be convening our Vaccines and Related Biological Products Advisory Committee on Tuesday, October 26th, so next Tuesday, to present those data and FDA's review of the data. Thank you very much.
Thank you for those updates, Dr. Fink. We'll move on to Health Resources and Services Administration.
Good morning. This is Mara Rubin again. Thank you for this opportunity to provide updates for Division of Injury Compensation Program activities. The National Vaccine Injury Compensation Program, VICP, continues to process an increased number of claims. In fiscal year 2021, petitioners filed 2,047 claims within the program, with $210.4 million was awarded to petitioners and $36.5 million was awarded to pay attorneys' fees and costs for compensated and dismissed cases. In addition, as of October 4, 2021, HRSA had a backlog of 1,477 claims alleging vaccine injury awaiting review. As of October 1, 2021, 3,158 claims alleging injuries and deaths from COVID-19 countermeasures have been filed with the Countermeasures Injury Compensation Program, including 1,357 claims alleging injuries from COVID-19 vaccines. About 82% of the claims are awaiting medical records for review, and about 77 claims are in medical review. More information can be found in the CICP website. Thank you.
Thank you, Dr. Rubin. Indian Health Service.
Good morning. This is Uzo Chukwuma. Thank you for the opportunity to provide an update for the Indian Health Service activities. I'm going to start off with our COVID-related activities. The Indian Health Service continues to maintain the COVID-19 vaccine task force that was initiated in September in response to the agency-wide allocation, distribution, and administration of COVID vaccines within the Indian Health Service, tribal and urban Indian health facilities. As of October 19, 2021, the Indian Health Service data from the CDC COVID tracker reported 2,162,835 COVID vaccines were distributed within the IHS jurisdiction, and 1,691,651 COVID-19 vaccine doses were administered by participating IHS direct tribal health programs and other Indian organizations that chose IHS for vaccine distribution. The CDC tracker also reports that 44.1% of the 2.1 million population has received at least one dose, while 36.6% are fully vaccinated. In early August, the IHS implemented a policy requiring COVID-19 immunization for all personnel working in the IHS facility as an added strategy to minimize the risk of COVID-19 transmission to patients and among staff. The IHS Vaccine Task Force also promotes vaccine safety among the American Indian and Alaskan Native population by reporting and monitoring 3 surveillance systems. The Vaccine Task Force actively encourages the use of the vaccine adverse events reporting. We also track adverse events that are reported in the IHS Safety Tracking and Response System, the ISTA, and routinely monitor surveys from IHS vaccine sentinel sites. The IHS collaborates with the CDC and engages the tribal leaders and IHS area offices on strategies to improve vaccine among American Indian and Alaskan Native populations. Moving on to pediatric immunization coverage improvements. The IHS routinely tracks pediatric immunization coverage. Long-term trends indicate a decline in immunization coverage for 2-year-old children. With COVID-19 pandemic, further decrease in coverage was observed. Before the onset of the COVID-19, the IHS immunization coverage for the 2-year-old series was at 64.7%. Coverage fell to 57.8% by the end of the third quarter, fiscal year 2021. In response to the declining childhood immunization coverage, in May 2021, the IHS implemented a pediatric immunization improvement initiative called Safeguard Our Future, Protect Tomorrow, Vaccinate Today. Strategies included a communication and focused on media content such as blogs, posts, provider and parent toolkits, and webinars to focus on the topic and to share best practices. The health informatics arm of the campaign concentrated on educating the healthcare community by using data and information technology tools to identify and reach out to patients missing recommended vaccines. The implementation focused on executing a quality improvement project that targeted changes in immunization workflow that result in improved and sustained pediatric vaccination coverage. The IHS continues working with tribes, states, and CDC to promote teen childhood and adolescent immunization. Moving on to influenza activities. The IHS Tribal and Urban Indian Health Program promotes influenza vaccination services to American Indian and Alaskan Native communities in the state. The IHS influenza-like illness surveillance system shows very low ILI activities for the 2020-2021 influenza season compared to previous seasons. In preparation for the upcoming influenza season, the IHS immunization program organized a series of kickoff activities that included webinars with presentations from influenza experts, dissemination of information such as the ACIP recommendations, discussions around influenza vaccine order, and resources for updating facility influenza action plans. Recently, the IHS collaborated with the CDC influenza vaccination team to incorporate the American Indian and Alaskan Native vaccination coverage information into the CDC National Influenza Vaccine Dashboard. That ends my update. Thank you.
Thank you, Dr. Chukwuma. We'll move on to the National Institutes of Health.
Hey, good morning. It's John Bagwell. I'll give the update for National Institute of Health. So the National Institute of Allergy and Infectious Disease posted the preliminary findings for the homologous and heterologous booster vaccinations for those that have received a EUA COVID vaccine. As noted by Dr. Fink, the findings were presented at VRBPAC last week. They'll be presented at ACIP tomorrow by Dr. Atmar, and they are also posted on the medRxiv server, so available for the scientific community. NIAID has also launched a phase 2 trial for people with autoimmune disease who did not respond to the original COVID vaccine. This is unique and interesting because it uses not only an extra dose, but is also exploring how to modify or pause the immunosuppressive therapy to improve the antibody response. NIAID also announced in September 3 large awards to conduct research and begin development of vaccines against multiple coronavirus types, including viral variants, and is an important step towards a pan-coronavirus vaccine. For non-COVID vaccine updates, NIAID announced the results of a HIV vaccine, the HVTN 705 study conducted in sub-Saharan Africa, which did not provide any protection against HIV. HIV has been
Thank you very much, Dr. Weigel. And with that, I'm just going to confirm. Okay, thank you. With that, we'll move on to the first session for the morning on pneumococcal vaccines. As a reminder, during today's meeting, I will invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. And if you wish to respond to a particular comment or question, please try and indicate this electronically, and I'll do my best to track on this. So I'd like to turn it over to Dr. Kathy Paling, chair of the work group, to provide an introduction and overview of today's session.
All right. Good morning. I want to welcome you to the pneumococcal vaccines presentation and on behalf of the pneumococcal vaccines work group. Next slide, please. I want to thank each and every member of the pneumococcal vaccines work group. The ACIP members, the ex officio members, liaisons, and consultants have all contributed greatly to this conversation. In addition, we would like to highlight and appreciate our CDC lead, Dr. Miwako Kobayashi. Next slide, please. The pneumococcal vaccine work group would like to highlight and say our sincere thanks to all the CDC contributors who have provided important information to guide these discussions, as well as our grade and evidence to recommendation consultants. Next slide. Would like to frame today's conversation. The policy questions presented at the September ACIP member meeting included a PCV15 age-based recommendation in series for persons over 65 years of age, and then a risk-based recommendation for PCV15 in series with PPSV23 for 19 to 64 with all kinds of high-risk medical conditions and factors. Then there were two PCV20 recommendations. One was an age-based at 50, and the other was an age-based at 65, and then the risk-based were based on that age group for high-risk conditions. And in that meeting, we are very appreciative of the feedback. Next slide, please. And the feedback was very clear. It was confusing to have different age-based recommendations by vaccine, and the request was to simplify the policy options for consideration for a vote. And the work group took this feedback seriously and rolled up our sleeves to figure out how could we address that. I'd like to move to the next slide, please. So first, we'd like to share that earlier on in the process, the work group created guiding principles, and we'd like to share what those were. Decisions on policy options should be supported by best available evidence. Simplifying existing pneumococcal vaccine recommendations could help improve vaccine coverage among adults. Disparities in pneumococcal disease burden and vaccine coverage should be reduced, and timely recommendations for each new vaccine should be made after FDA licensure. So with the feedback and these guiding principles, we will move to the next slide. We had many discussions and want to share the rationale for harmonizing at age 65 years. As was discussed at the last ACIP meeting in September, there is no data on the duration of pneumococcal conjugate vaccine immunity in adults. And so due to the potential waning of immunity, vaccination at 65 years and older may be favorable when risk of disease is higher. Second, when we reviewed the data for the cost effectiveness studies at 65 years of age and older, there was consistent cost savings, which means lower cost and better health outcomes compared to current recommendations in all the cost effectiveness analysis. The third rationale is that the proposed risk-based and age-based option provides an opportunity for higher pneumococcal conjugate vaccine coverage, which may prevent more disease compared with current recommendations and address health equity concerns. Next slide, please. So that leads to how, and we will be presenting more data to explain the updated policy questions for consideration, which are currently, should PCV20 alone or PCV15 in series with PPSV23 be routinely recommended to U.S. adults age 65 years of age and older? And second, should PCV20 alone or PCV15 in series with PPSV23 be recommended for U.S. adults aged 19 to 64 with underlying medical conditions or other risk factors? Next slide, please. And so here is what the proposal leads to: a single risk-based and a single age-based recommendation for pneumococcal vaccine. So 65 years and older, there is a single age-based recommendation. And for persons 19 to 64, those with chronic medical conditions, cochlear implant, CSF leak, or immunocompromising conditions would have a single risk-based recommendation. And for those without any of those conditions, there is no recommendation. Next slide. And so with that, we have provided an overview of where the conversation Dr. Mawako Kobayashi is going to lead us on considerations for age-based and risk-based use of PCV15, PCV20 among adults and proposed policy options. And afterwards, we look forward to a great discussion. With that, I'll turn it over. Thank you.
Thank you so much, Dr. Paling. We'll move on to Dr. Kobayashi's presentation.
Thank you, Dr. Lee and Dr. Paling for the introduction. Good morning. On behalf of the work group, I will present the considerations for age-based and risk-based use of PCV15 and PCV20 among U.S. adults and proposed policy options. Excuse me. Okay, all right. Currently, the 13-valent pneumococcal conjugate vaccine, or PCV13, and the 23-valent pneumococcal polysaccharide vaccine, or PPSV23, are recommended for use in U.S. adults. As a reminder, PCV15 contains the 13 serotypes included in PCV13, shown in yellow, and 2 additional serotypes shown in green. I will refer to these serotypes as PCV15 non-PCV13 serotypes. PCV20 contains the PCV13 serotypes, the 2 additional serotypes included in PCV15 in green, and the 5 additional serotypes shown in blue. I will refer to these 7 additional serotypes as PCV20 non-PCV13 types. And PPSV23 contains 4 additional serotypes that are not included in PCV20, shown in orange. I will refer to these serotypes as PPSV23 non-PCV20 types. Pneumococcal disease can be divided into invasive pneumococcal disease, or IPD, and non-invasive disease. IPD is less frequent, but a severe form of illness such as meningitis, bacteremia, or bacteremic pneumonia. Non-invasive disease is a more frequent form of illness, such as non-bacteremic pneumonia. Among U.S. adults 19 years and older, more than 100,000 hospitalized pneumococcal pneumonia cases, and approximately 30,000 IPD cases and 3,000 IPD deaths occurred in a year. 43% of the adult IPD cases occurred in persons aged 65 years and older, and approximately half occurred in persons 19 to 64 years with risk-based indications, indicating that more than 90% of adult IPD burden is in persons aged 19 to 64 years with risk-based indications and persons aged 65 years and older. In this presentation, I will refer to adults aged 19 to 64 years who are currently recommended to receive PPSV23 only as those with chronic medical conditions, or CMC, and those who are recommended to receive both PCV13 and PPSV23 as those with immunocompromising conditions, or IC. This graph shows the proportion of different vaccine serotype groups in adults aged 65 years and older. In 2018 to 2019, 27% of remaining IPD burden was due to PCV13 types, and 15% of all IPD was due to the 2 additional serotypes contained in PCV15. And approximately 30% was due to the 7 additional serotypes contained in PCV20. This graph shows the proportion of different vaccine serotype groups in adults aged 19 to 64 years with chronic medical conditions on the left and immunocompromising conditions on the right. Adults with chronic medical conditions had a higher proportion of PCV13 type disease compared with adults with immunocompromising conditions. However, the proportions of additional serotypes contained in PCV15 and PCV20 were similar. At the September ACIP meeting, we presented multiple policy questions on use of new PCVs, which led to concerns that the new options will be confusing and create more implementation challenges. After further review of data and discussions, we reframed the policy questions as, should PCV20 alone or PCV15 in series with PPSV23 be routinely recommended for U.S. adults aged 65 years and older? And should PCV20 alone or PCV15 in series with PPSV23 be recommended for U.S. adults aged 19 to 64 years with certain underlying medical conditions or other risk factors? This table compares the current and proposed options for an age-based recommendation. The proposed age-based option will apply to all adults aged 65 years and older, as shown on the right. The proposed risk-based option simplifies the current risk-based recommendations. The majority of the workgroup members were in support of using either PCV20 alone or PCV15 in series with PPSV23 for adults aged 65 years and older, and using either PCV20 alone or PCV15 in series with PPSV23 for adults aged 19 to 64 years with certain underlying medical conditions or other risk factors. A few members who were not in favor of these options did not agree mainly for the following 2 reasons. Some members preferred an age-based recommendation at age 50 years and older, since lowering the age-based recommendation may reduce disparity in pneumococcal disease burden in adults aged 50 to 64 years, and may provide more opportunities to vaccinate adults before they develop underlying conditions or when a more robust immune response is expected. Some members had concerns with the PCV15 options, given that it will need to be used in series with PPSV23. It is logistically more challenging to administer different vaccines in series. Providers need to know the vaccination history to correctly complete the vaccine series. If adults only receive PCV15 without returning for PPSV23, they will have lower serotype coverage. I will next review available data and workgroup considerations for these 2 points. First is on age-based recommendation at age 50 compared with age 65 years. The main reasons in favor of an age-based recommendation at age 65 years for both vaccines are Due to potential waning of immunity of the vaccines, vaccination later in life may be favorable when risk of disease is higher. For either PCV20 use alone or PCV15 use in series with PPSV23, an age-based option at age 65 was consistently cost-saving compared with current recommendations in cost-effectiveness analyses. The proposed risk-based and age-based options still provide an opportunity for higher PCV coverage, which may prevent more disease compared with current recommendations and may address some health equity concerns. First, on waning immunity issues. This figure shows the incidence of invasive pneumococcal disease in blue and deaths due to invasive pneumococcal disease in orange by age group based on CDC's ABCs data. The risk of pneumococcal disease increases with increasing age. This figure shows the life expectancy in years at age 50 and at age 65 years by race and ethnicity. U.S. adults at age 50 are expected to live about 30 more years, and U.S. adults at age 65 years are expected to live 90 more years. In the cost-effectiveness analyses, we assumed that the duration of protection from PCV vaccination is about 15 to 20 years. If adults are vaccinated earlier in life, they may not benefit from vaccine protection later in life when their risk of disease is higher. Next, cost-effectiveness analyses. As a reminder, cost-saving means that the intervention yields higher health outcomes and lower costs than the current recommendations in cost-effectiveness analyses, which is indicated in the right lower quadrant in green in the figure below. And LC and LQ refers to lower cost and lower health outcomes, or quality-adjusted life years, which is indicated in the left lower quadrant in the figure below. At the September ACIP meeting, Dr. Leitner summarized the findings from cost-effectiveness analyses conducted by CDC and other groups. This table summarizes the different scenarios considered in the CDC model for age-based use of PCV20 at age 65 and at age 50 compared with current ACIP recommendations. Use of PCV20 at age 65 years consistently showed that the intervention was cost-saving. Use of PCV20 at age 50 years resulted in worse health outcomes in some CDC scenarios, shown here as lower cost and lower qualities, which is the left lower quadrant in the figure. This table summarizes the results of cost-effectiveness analyses performed by other groups. Results from other groups also showed that PCV20 use at age 65 years was cost-saving in most scenarios. This table summarizes the cost-effectiveness analysis results on use of PCV15 in series with PPSV23 at age 50 or age 65 years. The CDC model showed that PCV15 in series with PPSV23 at age 50 resulted in lower health outcomes compared with current recommendations, shown as lower cost and lower quality in the table. The Merck model showed that the intervention prevented more disease than current recommendations, but the intervention was less cost-effective compared with use of the series at age 65 years. Therefore, the workgroup did not consider PCV15 use in series with PPSV23 for adults aged 50 years and older. In the CDC model, use of PCV15 in series with PPSV23 at age 65 was cost-saving in all scenarios considered. Lastly, higher PCV coverage and how that may address some health equity concerns. Risk-based pneumococcal vaccine recommendations have yielded low vaccine coverage in the target population. According to the National Health Interview Survey data in 2018, 23% of adults aged 19 to 64 years with risk-based indications had ever received any pneumococcal vaccination. By race and ethnicity, the Hispanic population had significantly lower coverage compared with the white population. By simplifying the risk-based option as shown to the right, vaccine uptake may improve in adults with underlying conditions. Another difference in the new risk-based option is that more adults will be receiving conjugate vaccines, since the 2 recently licensed vaccines are both conjugate vaccines. Conjugate vaccines have the capsular polysaccharide antigens conjugated to a carrier protein and induce a T-cell dependent response, whereas the polysaccharide vaccine does not. Based on available data, we use different assumptions for PCVs and PPSV23 for the duration of protection and vaccine effectiveness in the CDC's cost effectiveness analysis model, as presented at the September ACIP meeting. We assumed that PCV effectiveness does not decline for the first 5 years, whereas we assumed that PPSV23 had linear decline after vaccination. We also assumed higher vaccine effectiveness for PCVs compared to PPSV23. Approximately 90% of adults aged 19 to 64 years currently indicated for pneumococcal vaccinations are recommended to receive PPSV23 only. Under the new risk-based policy option, more adults will be recommended to receive one of the new PCVs, which may prevent more disease in this group. This could also help address disparity in pneumococcal disease burden to some extent. This figure shows the proportion of individuals with chronic medical conditions by race and age. The proportion of chronic medical conditions in the Black population, shown by the solid line, is higher in adults aged 50 to 64 years, compared with the proportion in the non-Black population shown in the dashed line. Therefore, the new risk-based policy option may prevent more disease in populations with higher burden of chronic medical conditions before age 65 years. Next is on use of PCV15 in series with PPSV23. The main reasons in favor of having an option of PCV15 use in series with PPSV23, along with the use of PCV20 alone, are the following. Use of PCV15 in series with PPSV23 provides broad serotype coverage. Use of PCV15 in series with PPSV23 at age 65 was cost-saving in CDC's cost-effectiveness analysis, as we saw earlier. PCV13 and PPSV23 series is currently recommended, so providers have experience using PCV in series with PPSV23. As a reminder, PCV15 provides protection against 2 additional serotypes not contained in PCV13, and PPSV23 provides coverage against 9 additional serotypes that are not contained in PCV15. Since 2012, adults 19 years and older with immunocompromising conditions have been recommended to receive both PCV13 in series with PPSV23, and all adults aged 65 years and older were recommended to receive PCV13 in series with PPSV23 from 2014 to 2019. In 2019, the recommendation on PCV13 use was changed to shared clinical decision-making in adults 65 years and older without immunocompromising conditions, cochlear implant, or cerebrospinal fluid leak. This graph shows estimated PCV13 and PPSV23 coverage in adults aged 65 years and older who are Medicare Part A or B beneficiaries. PPSV23 coverage is shown in orange. Coverage of both PCV13 and PPSV23, shown in yellow, increased gradually after the age-based recommendation in adults aged 65 years and older in 2014. The work group also discussed the possibility of a preferential recommendation for PCV20 over PCV15 in series with PPSV23. The main reasons in favor of a preferential recommendation were implementation challenges associated with use of PCV15 in series with PPSV23 and improved protection against the 5 serotypes included in PCV20 but not PCV15. The main reasons against a preferential recommendation were there are no studies directly comparing PCV15 and PCV20 efficacy and safety. The potential impact of PCV20 use alone is unknown, given lack of data on clinical outcomes. licensure of PCV15 and PCV20 were based on immunogenicity and safety, and the clinical relevance of lower immunogenicity for PCV20 compared with PCV13 is unknown. There are no PCV20 data in immunocompromised adults. Use of PCV20 alone will lose protection against serotypes included in PPSV23, but not in PCV20. For GRADE, we reviewed immunogenicity and safety data that compared the new vaccines to current vaccines. In 3 phase 3 trials that compared the immunogenicity of PCV15 to PCV13, both given in series with PPSV23, geometric mean titers, or GMTs, and percentage of seroresponders after receipt of the series were higher in PCV15 recipients for some shared serotypes. In 1 phase 2 and 2 phase 3 PCV20 trials, PCV20 recipients had lower responses by GMT and percent seroresponders in most shared serotypes shown in yellow in the table below. However, in the phase 3 trials, PCV20 met non-inferiority criteria for all 13 shared serotypes by GMT ratio. In our GRADE assessment, the certainty of evidence on the benefits of PCV20 use alone in adults with chronic medical conditions or immunocompromising conditions was low. Correlates of protection are not established, so the impact of these findings against the critical outcomes are known. Also, the studies targeted generally healthy adults and did not include immunocompromised persons, so the studies are not representative of the populations considered for the risk-based policy option. In adults aged 19 to 64 years who currently have pneumococcal vaccine indications, the 4 serotypes included in PPSV23 but not in PCV20 comprise 12 to 15% of all IPD burden. In adults aged 65 years and older, these serotypes comprise 8% of invasive pneumococcal disease in adults aged 65 years and older, when PPSV23 coverage was estimated to be around 50 to 60%. The impact of losing protection against these serotypes by use of PCV20 alone is unknown. Here's the summary of workgroup considerations for an age-based option for adults 50 years and older and 65 years and older. The main reasons in favor of an age-based option at age 50 were the possibility of reducing disparity in disease burden in adults aged 50 to 64 years, and the possibility of providing more opportunities to vaccinate adults before they develop underlying conditions. The reasons in favor of an age-based option at age 65 were the potential for waning immunity makes it favorable to vaccinate later in life when risk of disease is higher. The age-based option at age 65 was consistently cost-saving in cost-effectiveness analyses. And the use of the new risk-based and age-based options still provide an opportunity for higher PCV coverage in adults compared with current recommendations, which may prevent more disease and address disparity issues. Here's the summary of workgroup considerations on PCV20 use alone and PCV15 use in series with PPSV23. The advantages of using PCV20 alone are: it is acceptable and feasible to implement a single vaccine option. The intervention was cost-saving in most cost-effectiveness analyses. And it is expected to provide better protection for the serotypes that are covered by PPSV23 alone. The potential disadvantages of using PCV20 alone are: the clinical significance of lower immunogenicity compared with PCV13 is unknown. There are no data in immunocompromised adults. And use of PCV20 alone will lose protection against serotypes contained in PPSV23, but not in PCV20. The advantages of using PCV15 in series with PPSV23 are: the combination will provide broad serotype coverage. An age-based use at age 65 was cost-saving in CDC's cost-effectiveness analysis. The disadvantages of PCV15 use in series with PPSV23 are: it is logistically more challenging to administer PCV15 in series with PPSV23. Providers need to know the vaccination history to correctly complete the vaccine series, and the intervention can result in lower serotype coverage if the series is not completed. Unlike PCV13, PCV15 and PCV20 were licensed for use in adults first. PCV15 licensure for use in children is expected to happen in early 2022 and in 2023 for PCV20. At this point, how the use of these vaccines in children might impact the disease burden in adults is unknown. Based on these considerations, here is the proposed language for the age-based recommendation. Adults 65 years of age or older who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV20 or PCV15. If PCV15 is used, this should be followed by a dose of PPSV23. Here's the proposed language for the risk-based recommendation. Adults aged 19 years of age or older with certain underlying medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV20 or PCV15. If PCV15 is used, this should be followed by a dose of PPSV23. I would like to pause here and I would be happy to take any questions. Thank you.
Thank you very much. I just want to thank you, Dr. Kobayashi, and Dr. Paling for your leadership of this and for taking the committee's comments from the last meeting into consideration. We really appreciate that and the incredible work of the work group. I'm going to actually hand it over to Dr. Cohn briefly. She wants to make a quick statement, and then we'll open it up for discussion.
Thanks, everyone. I just want to acknowledge that the pneumococcal work group approach to their proposed recommendations has shifted since the last meeting in which this was discussed, I think September of 2021. And just let everyone know that this, and this was just demonstrated clearly in the presentation, but I just wanted to reiterate that implementation of the adult program is really of critical importance right now. And the discussions that occurred at CDC and among the work group were that having two different age-based recommendations would be more confusing, and the need to simplify these recommendations to potentially improve coverage was really critical. So I just wanted to say that we know this have shifted, and if the ACIP members want to go back and discuss the age 50, we are more than open to that discussion. But the concern from CDC was related to program implementation and the adult program. I will end there.
Terrific. Thank you so much. And this presentation is now open for discussion, and I see Dr. Talbot's hand is raised. Dr. Talbot.
Yeah, I really want to commend the work group, not me. I am on the work group, but that's not what I'm talking about. Dr. Paling and Dr. Because this was incredibly difficult. But I do want to speak a little bit. They mentioned the majority opinion, and I wanted to speak up a little bit about the minority. I am an internist, so I look at this as an internist. And I want to say that the majority of the physicians who took care of adults really wanted the age 50. So there were some that did not, but the majority of physicians who take care of adults were very interested in starting at age 50. We do recognize that we do not know the duration of protection if we vaccinate at 50, but as adult physicians, we are more than happy to evaluate a booster in the future because we hope that our patients live long enough, have long and meaningful lives to require a booster. If that would require the 15 plus 23 to be thrown in at 50 years of age, I wouldn't like it, but I would be willing to do that, to lower the age, to capture people when they're most likely to respond to a vaccine and to reduce the current disparities a disease that exists. Okay, thank you.
Thank you. Dr. Daly?
Yeah, thanks so much. So I greatly appreciate the work group's efforts to simplify, because I do think simpler recommendations, tend to achieve greater success at the implementation phase. But I do want to bring up the idea about the challenges of risk-based recommendations. I mean, I think in a couple of weeks we'll be talking about the fact that risk-based hepatitis B vaccination recommendations in adults haven't achieved that as high coverage as desired. So did the work group talk about other means to make sure that risk-based recommendations in the 19 to either 50 or 64-year-olds would be successfully implemented to the extent possible? I realize that's challenging, but I think given the conversation we're going to have about hepatitis B in a couple of weeks, I think we should discuss that over.
Thank you, Dr. Daly. This is Dr. Kobayashi for the comments. We didn't go into the details about the specifics of implementation, but the hope was that when we started by simplifying the recommendations, because the current challenges, there are different tiers of risk-based recommendations currently, and that's part of the reason why it's leading to implementation challenges. We're hoping that having this one single risk-based recommendation will address some of that challenges, but I acknowledge that there will be probably more efforts needed at the implementation side.
Thank you. And I see Dr. Paling would like to also make a comment or respond.
Thank you, Dr. Daly, for that really important comment. One of the things is we don't know, and there's not much data, but what we did do was we reflected on what happened in children with the flu vaccine. We had for many years had a high-risk recommendation for children with influenza, and it was had very low uptake. And when the 6 to 23-month children started to have an age-based recommendation, there was a significant jump in the risk base. And so the thought was that with a consistent, clear age-based recommendation and a simplified risk condition across age groups, that would enable much clearer communication and that patients and physicians could advocate for better coverage. Thank you.
Thank you. Dr. Bell?
Thank you. I also just wanted to thank the work group for their efforts to simplify these recommendations, which I think is really very, very important for implementation considerations. And I also wanted to remind, at least, or say that from our work with COVID-19 vaccines, it's quite clear that the proportion of the population aged 50 to 65 that have chronic medical conditions broadly defined, as I understand the way we're defining it for this recommendation, is very large. And so while I recognize the concerns about implementation of risk-based recommendation, this is a huge part of the population of 50 to 65-year-olds. And I think perhaps one of the things that we might want to do is be clear in our communication to providers that when we say risk in this context, we're talking about probably close to three quarters of their patient population. So I think we have an opportunity to provide vaccine in the 50 to 64-year-olds relatively broadly. And I do question in the trade-off between simplicity and implementation and additional coverage, what the incremental benefit actually would be to dropping the age down to age 50 for the conjugate vaccine, the 20-valent conjugate vaccine.
Thank you. Ms. Bata.
Thank you, and thank you, Dr. Kobayashi, for this really thorough explanation of the evolution of this recommendation. I am still wanting to express, similar to what Dr. Bell and Dr. Talbot have said, that I'm concerned that we are going to miss a lot of
people under 50, and that those that might not be included in this are going to be from our diverse populations. And I know that cost effectiveness does contribute a large component of looking at these recommendations, but I also think that we need to think about a policy that is equitable and that it may cost more, but it may actually reduce the mortality and morbidity in some of our diverse communities. And so I'm still really struggling with wanting to bring that age-based recommendation down to 50. Thank you.
Thank you. Dr. Cotton?
I wanted to thank the group for providing clarity in the recommendations, as it's been fairly confusing for clinicians in the field to understand what the appropriate recommendations are. So thank you for that. I did want to highlight the issues regarding possible clinician confusion between various vaccines and various definitions of medical conditions and immunocompromised host. We've had different definitions for COVID-19 and pneumococcal, and we'll talk more about the shingles vaccine and immunocompromised hosts. So I really just want to put a plug in to advocate for standardization of the definitions, and especially for immunocompromised patients. And I think that that's something that we should think about pushing forward eventually. Thanks.
Thank you, Dr. Cotton. Dr. Long.
Yes, I agree with everybody. This is very difficult. I just want to, I understood and everybody understands that if we looked at the severe morbidity, hospitalizations, intensive care unit, and deaths, more than 45% occur to these, to pneumococcus. More than 45% occurred in those over 65, and more than 45% occurred in those with underlying conditions. So if we did both of those groups well, we would prevent the vast majority of vaccine-preventable pneumococcal disease. The concern about going to 50, and it is understandable, as you saw from the data, that between 50 and 65, lots of people do add underlying medical conditions, but many of those, most of those, are not going to compromise how they would respond to a vaccine. And unlike hepatitis B, which risk is based on behaviors, this is not behavior of anybody except your doctor to recognize if you have any of these diagnoses, it's time for you to get immunized a little bit earlier. And my concern about 50 is that if we went to 50, I think we would have much more difficult in promulgating either 20 or 15 plus 23, because the 23, if used in many otherwise healthy Americans, would raise the possibility of a blunted response to subsequent immunization that almost certainly would be required. My few thoughts. Thank you.
Thank you. Dr. Saneas.
Thank you. As a primary care physician, I also greatly appreciate the efforts at simplifying the recommendations in order to facilitate implementation. But given that we don't have any data for PCV20 for immunocompromised individuals, has there been any consideration for using PCV20 for age-based recommendation, either at 50 or 65, and then using PCV15 in series with PPSV23 for those with immunocompromised or medical conditions?
Hi, yes, thank you for your question. So we did have that discussion early on when we started the discussion, but in the end, the truth is that we don't have really data for, even for PCV15, it's based on immunogenicity studies. So we really don't have data on how the series would have what kind of clinical impact we can expect from either vaccine. So that was the truth. So in the end, we decided to go with the options that we have presented in the previous ACIP meetings. Thank you.
Thank you. And I just want to take a moment. If you have had a chance to ask your question, please put down your hand. And if you would like to raise it again, that would be terrific. I will move on to Dr. Brooks.
Yes, and good day. And I really do appreciate the work group and Dr. Kobayashi working to simplify the recommendation. A couple things. First, it sounded like if the difference between PCV20 and PSV23 was only 8% difference in terms of illness due to those three serotypes. Is that correct?
Yes. So in age 65 years and older, the proportion of serotypes caused by additional serotypes included in PPSV23, but not in PCV20. I think this is what you were referring to.
Right there.
Was 8%.
Right. Okay,
yes.
Good. So I think that the thought about using PCV20 versus in series with PPSV 15 in series with PPSV is not as strong because you're losing 8%, and when you look at 30,000 cases, 30,000 deaths, that 8% is a relatively small number. So I'm leaning in favor of using PCV20 by itself, just for simplicity. The other thing I think that, more importantly, the point that Dr. Bell and Dr. Long made, I think is really relevant. Starting at 65 for the age-based and then going to risk-based below that category, 18 to 64, is the simpler way to approach it. The concern about those 50 to 64 is a higher incidence African-American population of death and hospitalization with invasive pneumococcal disease. But again, likely a lot of that is explained by underlying conditions. And so with the recommendation, if we do go that way, we would be very clear with the statement that if you have a patient with an underlying condition, which is going to be, as stated, 75% of your patients, you give the vaccine. And I believe that in the end, vaccines don't work unless they're in someone's arm versus in the refrigerator. So if we make the recommendation relatively simple and then emphasize why it was done this particular way, that we will ultimately save more lives that way. And then one final quick question. There was a statement about PCV20 and clinical effectiveness. So what all we have is immunogenicity and no actual real live data regarding the efficacy of PCV20. Is that correct?
That is correct. We only have immunogenicity studies.
Right. So that's my one concern with PCV20 alone. Thank you.
Thank you. Dr. Talbot.
Yeah, I wanted to really thank the pediatricians in the group who feel like the internist can keep up with all of these simple recommendations. It would be true if the majority of our patients didn't have multiple comorbid conditions. We are not, we would like to think of ourselves as physicians who prevent, but by the time we see many of our adults, we are already in therapeutic mode and don't have as much time for all the necessary preventative measures that are expected of us. So having age-based recommendations greatly changes how we practice and doesn't require us to go through the list of the 20 different health comorbidities that are required for every single vaccine, in addition to mammograms and colonoscopies and everything else. So while I appreciate the pediatricians talking about it's simple for us to do, it's very difficult to do in a clinic where you're very therapeutically minded. And so I just want everyone to keep that in mind, that when you look at a group that's 50 to 64 that has lots of comorbid conditions, it is much easier to simplify the vaccination process to do that. That's the first thing. The second thing is that is an age group that will respond to vaccine and create a lasting vaccine response much better than someone at 70. So I want I want all the pediatricians to kind of keep that in mind. As your immune system for your little patients are getting better and better, ours are not. And so it's a very different viewpoint. Thank you.
Thank you, Dr. Talbot. And actually, if my colleagues will allow me, I wanted to respond a little bit and also just add a few comments, and then I see some more hands raised. First, I wanted to, again, emphasize that a couple of points. One is that I do think, as Dr. Brooks mentioned, vaccines don't save lives, vaccinations actually do. And so the importance of getting vaccines into arms can't be understated. The second I wanted to point out is that there are many providers giving coverage, and including pediatric and family practice providers. And it's really important that I think we give providers flexibility and choice on what they stock in their offices. And I can't underestimate that enough, because we recognize especially private providers are often purchasing vaccines out of pocket, and they need to efficiently use those vaccines before they expire. And so, your choice may differ depending on sort of who your population is and who you're serving, with the recognition that Dr. Kobayashi also mentioned, which is the sort of anticipated request for expansion of use in the pediatric population. So I can imagine as a pediatric provider, it would be far easier for me to stock PCV 15 if I was seeing both kids and adults, or as a family practice provider. And the third thing I wanted to emphasize, and this goes back several maybe a couple of years ago, to ACIP meetings, where we had these discussions, and I will call out Dr. Paul Hunter, who reminded us of this in many ways, in that the most important and most effective intervention that we have seen has been pneumococcal conjugate vaccines delivered in childhood. And that actually has had the biggest impact on adult burden of disease, more so than our individual vaccines into adult arms. And so in order to be able to address equity, which we are very much concerned with, I would actually argue that childhood vaccination programs are really going to address equity at a population level more meaningfully than perhaps individual vaccines. The final point I guess I will make is that we are asked to make decisions that are challenging and difficult, where we are trying to maximize the benefits and minimize the risks to individuals in the population, and also consider resource use. And I think this challenge of risk-based populations keeps coming up over and over again, and I don't have an easy answer for it, but I will say that we as a community probably need to think about doing better, because every vaccine that's coming at us these days is targeting a risk-based population, and it becomes harder and harder for us to lean on a universal vaccine approach as a way to address equity or coverage. Again, recognizing that it can be more effective in certain situations, but I don't think it's the answer all of the time. And with that, I'll conclude my comments, and I'll actually call on my colleague, Dr. Lair.
Good morning. I wanted to comment on the thought that 33/4 of people aged 50 to 65 have conditions that would make them eligible for the vaccine. If that's true, then I would absolutely agree with going down to age 50, but I'm not sure that's accurate. That's not my experience. And so I would like to see some data, because if that's true, it's just much easier to say, let's just cover everybody because we're getting the 75% of the people that we need. My major concern with age 50 is twofold. One is the decline that is probably going to be over 15 years in needing a booster, and I recognize that we can do a booster 15 years from now and we'll have more data. However, the PCV 15 and PPSV 23 is not really cost effective at age 50. And so I'd be hard put to say that I want PCV 20 at age 50, but I don't really want PCV 15 and PPSV 23 until age 65. And that's too awkward for me. So I don't have a strong feeling against going down to age 50, but it's not my preferred option. And I would probably err on the side of going to age 65. Thank you. Over.
Thank you, Dr. Lair. Dr. Sanchez.
Thank you. I actually do want to thank and commend the work group for simplifying the recommendations. It's much clearer, much more focused. And I do tend to agree with the 65-year cutoff, although I don't see the adults over 50s. I do hear Dr. Talbot, and that maybe should be another consideration as well. But my question is that essentially these recommendations would supplant the current ones for where the conjugate vaccine, the PCV13, is given based on a decision-making, on a shared decision-making. So we're now going to be recommending for all 65 years and over or 50 years and over, whatever the ultimate decision is, that all should get the conjugate vaccine, and then with the PCV15, the PPS 23 valent. So we're not given an option anymore for just the PPS 23. Is that? I just want to clarify that. Thank you.
Thank you, Dr. Sanchez. This is Dr. Kobayashi. So yes, that is the language that we're proposing right now.
Thank you. And I want to transition for a moment. We have had a request to have our colleagues from Pfizer and Merck be able to make a few comments. I will invite our colleagues from Pfizer to speak first. Max of 3 minutes, please, for each of the speakers. I don't know who is speaking on behalf of Pfizer today.
Yes, thank you, Dr. Lee. I'm Luis Joder, Chief Medical Officer for Pfizer Vaccines. Do you hear me?
We can. Thank you, Dr. Jodar.
Thank you. Thank you very much to you and the members of the ACIP for this opportunity to speak to you today, and to Dr. Kobayashi for a great presentation. On behalf of Pfizer, we would like to provide 3 brief comments on today's presentations as you prepare for your further discussions and vote. Firstly, I think as it was mentioned by Dr. Khan, the updated policy options considered today constitute a drastic change of the policy options that were discussed and reviewed during the June and September ACIP meetings. The policy options discussed in these meetings clearly separated the 2 proposed pneumococcal conjugate vaccination strategies for adults, namely PCV20 and PCV15. And the conclusions of the EPRs and presentations in June and September for PCV20 alone at 50, 65 age base, 1949 and 1964 risk base were very favorable toward the intervention, were either cost-effective or cost-saving and a good use of resources. In contrast, all the ETR conclusions for the other proposed intervention given in series were mixed and more uncertain, with no clearly favorable conclusions. Yet today the ask is to vote on the remaining options equally. But we believe that these options are not equal, as evidenced by the very different ETR conclusions presented at previous meetings. So for these reasons, and regardless what at the end of the day the committee decides, we respectfully ask the committee vote on each intervention separately based on the relative merits. Secondly, the work group has provided 3 points of the rationale for harmonizing to the 65-year-old age group. And these 3 points are complex, as the discussion today has shown. And again, we believe that they merit further discussion by the work group and the ACIP. Of more concern to us is also the potential downstream effects of age-based and risk-based recommendations on promoting or exacerbating disparitely and consequently health equity, as it was pointed out in the previous ETRs, and I think some of the members have mentioned here. Regarding the potential complexity of having 2 different age-based cutoffs, there is precedent for ACIP making such recommendations. For example, the 60-plus recommendation for Zostavax and the 50-plus recommendations for Shingrix. Thus, a pneumococcal intervention at 50-plus and a different one at 65-plus can be implemented too. So we respectfully ask the committee, and I think that's what you are doing, to reconsider either now or in the near future the use of PCV20 at age 50 for the reasons outlined by the work group previously. And finally, we respectfully ask the committee to provide guidance for those people previously vaccinated with PCV13, PPSV23, or both, to have the option to receive the additional protection provided by PCV20. Currently, people such as the immunocompromised may have received PCV13 almost 9 years ago and could benefit from receiving a dose of PCV20. We stand ready to work with you all to provide any additional data to support such deliberations. And just to finalize, as a personal note, I would like to thank Dr. Amanda Kong for her partnership over the years, and wish her the best. Thank you very much.
Thank you very much, Dr. DeLauer. I will invite our colleagues from Merck to join. Is it Dr. Haupt?
Yes, it is, Dr. Lee. Can you hear me okay?
We can. Thank you. Please go ahead.
Yeah, thanks. Good day. This is Rick Haupt. I'm the head of Infectious Disease and Vaccines, School of Medical Affairs at Merck. We want to thank the ACIP for allowing us to make public comment today regarding the deliberations and upcoming vote later. We also want to thank the pneumococcal work group for all its efforts to ensure a simplified recommendation for adult pneumococcal vaccination. We agree that the proposed language is consistent with the principles set forth by the working group at the beginning of the adult vaccination policy review back in October of 2020. My first comment is I want to go back to comments I made in September and information we provided to the working group about PPSV hyporesponsiveness, and state unequivocally that scientific evidence does not support the hypothesis of a PPSV-induced hyporesponsiveness when there's an adequate interval between doses. PPSV sequential regimens are not detrimental to booster immune responses in adults. My next comment, as reviewed at the September 29th ACIP meeting, the final recommendation language proposed by the work group is economically favorable and consistently cost savings across various scenarios. The language being proposed today allows healthcare providers the option to choose between sequential PCV15 PPSV22 regimen or a single-dose PCV20 regimen based on the risk profile of the individual being considered to be vaccinated. We also expect that the current risk-based recommendation will significantly address equity, especially in the 50 to 64 years of age group, which has been the subject of much discussion during these ACIP deliberations. In this age group, immunocompromised and individuals with chronic medical conditions account for 30% of the population, but contribute 70% of the pneumococcal disease burden. Therefore, it is reasonable to focus on this population using a risk-based approach. We should note that Merck has already begun taking orders for PCV15 and will begin distributing doses to customers in the coming weeks. We expect to have sufficient supply to meet the demand for a recommendation in both the 65-year-old age-based cohort as well as the 19 to 64 age cohort with underlying medical condition and risk factors following today's vote. And then finally, we would like to thank the work group members and the ACIP members for all their efforts and deliberations regarding the adult pneumococcal vaccine policy. We look forward to working with the work group as they start deliberations regarding the pediatric pneumococcal vaccines policy after the conclusion of the adult policy today. Thank you.
Thank you very much. And I want to thank my colleagues, the liaisons who are waiting so patiently to make a comment. So we'll go in order. Dr. Freihofer.
Sandra Freihofer, American Medical Association. Speaking as a practicing physician, excellent presentation and discussion. And I agree with Dr. Talbot that there are many, many adults over the age of 50 to have multiple medical comorbidities. And I greatly appreciate the work group's attempt to simplify the recommendation. But I'm thinking about real life implementation. As we know, vaccinations are not always recorded as completely in registries as we would like for them to be. So tracking down which vaccine has been received is challenging and sometimes really impossible. What is the downside of a patient receiving a PCV20 and a PPSV23? And an additional clarification, for the CSF leaks and the cochlear implants, are you recommending an additional PPSV23 dose at 65 or 5 years after the previous PPSV23 dose?
Thank you, Dr. Freihofer. So for the first question about the downside of PCV20 plus PPSV23, so we, again, for all, both PCV15 and PCV20, we're basing our assumptions based on available immunogenicity and safety data. We did initially discuss the option of PCV20 in series with PPSV23, but when we did the cost effectiveness analysis, use of PCV20 alone as an age-based recommendation that already was cost saving, meaning preventing more disease and cost compared to the current recommendations. And then while adding PPSV 23, prevented additional disease, it became the incremental cost was much higher. So the additional disease save for the was a lot more expensive. So because of that, we decided to go with the PCV 20 option. So that's the first question. And I'm sorry, could you please repeat the second question, please?
Yes, and the prior pneumococcal recommendation, so to clarify, it's not a safety concern, it's just a cost concern. So there's no safety problem with if someone got the PCV 20 and then the PPSV 23, is what I'm understanding. So the second question is, in the prior pneumococcal recommendation, for those 19 to 64 that had cochlear implants or CSF leaks, the recommendation was to give an additional PPSV 23 dose 5 years after the previous one, or after age 65, whichever was later.
Oh, yes. Thank you. So we are still discussing what kind of guidance we'll provide for people who previously received the recommended vaccination, including discussions about what to do with people who received the risk-based recommendation earlier in life. So that is to come in the clinical guidance. But thank you for bringing that up.
Thank you. Dr. Goldman.
Thank you so much, Jason Goldman, speaking as a private physician dealing with these patients every day, but also by the American College of Physicians, speaking as an individual. Not to fully reiterate all the points that were previously made, which were excellent. When we deal with these patients, we have so much to deal with, as Dr. Talbot said, not just managing their diabetes, hypertension, heart disease, explaining the medications to them, convincing them why they need the medicine, recommending their eye exam, their foot exam, their colonoscopy, their mammograms, as well as all the other vaccines that they need as an adult. And as someone who teaches my colleagues at annual meetings the vaccine schedule and what they should be doing, what history has shown us is these risk-based recommendations are confusing, onerous, and actually are a barrier to access to care. When it is as simple as age 50 and above, you get your vaccine. That's easy to digest, easy to understand. It is safe for the patients, and it allows for more patients to get adequately vaccinated. And while I truly appreciate the work of the ACIP having to look at the population, my primary concern is the patient sitting in front of me and what is going to reduce their risk. So having a simplified age-based recommendation at 50 and above is going to dramatically, in my opinion, improve access to vaccination, is going to allow my colleagues to very quickly, easily digest the new recommendations, provide it to their patients, and be able to make sure they get the vaccines that they need, and we're going to prevent a lot more disease. Additionally, with the PCV 13 issue we had, it wasn't that it was a bad vaccine, but it was such a good vaccine that we put at it by giving it at an earlier age prevented the disease burden in adults. So by lowering the ages, we're actually covering more people. And my concern, especially with equity, that many of the minority patients aren't living long enough to benefit from vaccines by age 65 because of social determinants of health. So there's a lot of reason to go down to age 50. And my one final point as far as ease of use, for me as a private physician, a single dose vaccine that I can give even if I have to do a booster in 15 years is a lot more preferable than having to deal with intervals where patients are not always coming back for their second dose. They don't go to the vaccine registry. We don't know when they got the vaccine, and it is much more burdensome having to deal with an interval-based type of vaccine as opposed to a single vaccine to improve coverage. Thank you.
Thank you. Dr. Schmader.
Thank you. This is Ken Schmader representing the American Geriatric Society. And gosh, what a terrific job by the work group. AGS wants to go on record supporting the current proposed age-based recommendations for adults 65 years of age and older, as stated on the slide. Based on the evidence and advantage presented beautifully by Dr. Kobayashi and in agreement with the majority of the work group members, he's certainly not opposed to an age-based recommendation 50 and older if a booster is available and effective. Over.
Thank you, Dr. Schmader. Carol Hayes.
Yes, Carol Hayes speaking for the American Nurses Association, but I'm making a comment from the National Association of Hispanic Nurses. They have gone on record as strongly urging the committee to consider expanding access to pneumococcal vaccines. The benefit of the pneumococcal vaccine is both to the recipient as well as to the indirect vaccine benefit for non-vaccinated populations. The association supports the following recommendations that specifically impact the Hispanic population. Support for expansion of recommended age range to include those 50 years of age and over. Support in the use of a single-dose vaccine regimen to ensure uptake and access to equitable preventative care, and to ensure access to those in the Hispanic community and increase efforts to reduce health inequities related to vaccines. Their comments are much longer. We are going to be uploading them to the public comment section so that you can read the full document that they submitted for your review. Thank you.
Thank you. Dr. Grog?
Yes, as a representation of the American Osteopathic Association with primary care, simplification would be the use of a single vaccine rather than two vaccines. But on that same inclination, we haven't discussed the time period. Do you give the PCV15 and the polysaccharide at 8 weeks apart or 1 year apart? And either way, it's going to decrease compliance, I would feel. Thank you.
Thank you very much. I see Dr. Bell's hand is raised. Before we go back, I wanted to just ask maybe Dr. Bell and other ACIP members if they would offer a comment on their support for the proposed recommendation. So Dr. Bell.
Yes. First, I just want to sort of make one bigger picture comment about this idea about risk-based versus age-based recommendations, and caution people not to assume that a risk-based recommendation that focuses on a behavioral risk factor like we will be considering with hepatitis B is necessarily in the least bit transferable to this recommendation. We're talking about health risks. So I would be careful about that. And I also, at some point or another, would love to hear actual data, not in the pediatric population where we also have school entry requirements and such. I would love to hear actual data that show that expanding a recommendation from a risk group to an age group makes a large difference in terms of coverage, because I think everyone thinks that that's the case, but I'm not exactly sure that it is the case. And so, again, I think we just want to I am concerned about lumping when maybe there is no lumping necessary, or not, the lumping isn't appropriate. In terms of how do I feel about this recommendation that's on the table, I'm in support of this recommendation. I'm not totally opposed to the idea of dropping the age group down to age 50, but I support the work group's final suggestions to us and would be happy with it.
Thank you, Dr. Bell, for your comments. And I'm right now showing the coverage data that we have for herpes zoster. And then, with the understanding that this is a, different vaccine, we're talking about different disease epidemiology. But just as an example of a vaccine that has an age-based recommendation for younger, that starts at a younger age, at the time of implementation in 2006, it was for all adults 60 years and older. And then as of 2018, the data of 60 to 64 years shows low coverage, and there are disparities. So I just do agree that we do want to make sure that changing the option is one thing, but ensuring that implementation actually follows is probably the key. Thank you.
Thank you. And just to clarify, Dr. Bell, while I still have you on the line, what is there a preferred age-based cutoff that you have? Dr. Bell?
I'm sorry, Dr. Lee. I was having a little trouble hearing. I missed that. What did you just ask me?
Yeah, I was just wondering if you could clarify if there is a preferred age-based cutoff you would have.
I prefer the adult 65 years of age or older. I think that the incremental benefit of going from age 50 with chronic conditions to all age 50 is low, and I particularly feel that the incremental benefit is likely to be low when we keep in mind the fact that we're going to have pediatric vaccination with the new pneumococcal conjugate vaccines in the foreseeable future, and I think that that's going to greatly change the epidemiology, and we might be looking at things in a completely different way at that time. So for now, I favor age 55.
Thank you. Dr. Long.
Yes, I would like to echo Dr. Bell's sentiments and agree with the 65 and older. One thing I want us to remember is that we're talking about serotype coverage. For instance, someone mentioned maybe 8% of serious disease or lives would be lost if just from PCV 20 without 23, for instance. And we know that the polysaccharide vaccines perform very poorly. And so if there's anything we are hoping to do in the near future would be to eliminate those polysaccharide vaccine, pure polysaccharide vaccine. And we do suspect, because of the miraculous performance of conjugate vaccines in younger individuals, that the conjugate vaccine 20 would likely perform and eliminate any potential 8% serotype loss from not giving the full 23. And the other thing is, because we lack all efficacy data on both of these new vaccines, I would like to just at this moment deal with the 65 and older, for which it is clear there would be a benefit of either thing that we recommended, and not go down to an age-based of 50. Thank you.
Thank you so much. Ms. Hayes, your hand is still raised. I just want to confirm that that's from before. Are there any additional comments from ACIP members? Oh, thank you, Dr. Lair.
So I have a logistical question. My sense is that everyone agrees with an age 65 age-based recommendation. I don't have a clear sense of the room for an age 50 recommendation. And so if I were voting, I would vote for the 65, and I personally would not vote for the 50. But I think if we voted for the 50 first when the vote comes up, that would let us know if that would pass, and then we wouldn't have to vote for the 65. But I'm just suggesting that when we come to the vote, we might want to vote for the 50 first. Suggestion. Thank you.
Thank you, Dr. Lair, for stating your preference. Any other comments from ACIP members? I'll actually go on record and state that I do think that the 65 and older recommendation as a cutoff makes the most sense, given the data that we have in hand at this moment, and also taking into account the broader context of the pneumococcal conjugate vaccination program. And I would not be in favor of lowering the age down to 50. I would also just emphasize that what was brought up before, which is we don't have efficacy data, we have immunogenicity data. Dr. Talbot.
As an internist who treats adults, I would like to go on record that I would reduce the age to 50. And if possible, would like to vote on that first before 65, but understand my pediatric colleagues may not agree. Thank you.
Just to clarify, Dr. Talbot, are you saying 50 for both PCV 15 and PPSV 23 as well as PCV 20?
Yes, and I'm not worried about the cost effectiveness of the PCV 15 followed by the PCV 23, because I think most practices would rather invest in one vaccine than two. So I'm not worried about that not being cost effective. I just don't think it'll get used. think I would move both down to 50 and go from there.
Dr. Paling.
I want to say thank you to everybody and for this robust discussion. And as you can get a flavor of, we've had robust discussions within our work group as well. And I too am leaning strongly on the lack of effectiveness data for PCV 15 in PCV 20, and knowing that we're going to be having childhood vaccinations being expanded to include these vaccines in the near future. And so with that, one of the things, so I'm in favor of the 65 and older, but I would like to put out that it would be very important in 5 to 7 years to review the effectiveness of these vaccine recommendations and revisit that, because there's a lot that we're making our best estimates on, and I believe that real world data will be very important in guiding future decisions. Thank you.
Thank you. Dr. Sanchez, you had your hand raised briefly. Would you like to make a comment?
No, thank you. I agree with the previous comments about the age 65 cutoff. That's what I would favor. And I was just wondering, in all fairness, whether to the internists, whether there should be a separate vote for 50 years of age or over, so at least we can go on record for that, 50 to 64 years as well. That's my comment.
Thank you. We'll take that under advisement. Any other comments or questions? Oh, sorry, Dr. Zimmerman, go ahead.
I would, Rick Zimmerman, University of Pittsburgh. I would like to just add, of course, the antidote always sticks in your mind, but of a woman in my practice who had pneumococcal bacteremia with joint tendon involvement less than 65, for whom an age-based 50 might have given her protection. Of course, we don't know which serotype she was infected with, but there are some burden of people who are less than 65 who don't have, and over 50 or over who don't have an identifiable risk factor who would benefit from an age-based recommendation. My practice is a federally qualified health center in the inner city. Thank you.
Thank you. I do not see any additional hands raised in this moment. What I would like to suggest is that we take a 10-minute break so that we can confirm the proposed language going forward, and then we will reconvene at 21 after the hour. Thanks, everyone. All right, everyone, welcome back. We are ready to reconvene, and we are going to walk through sort of what the process will be, but I'm going to ask Dr. Kobayashi to please put up the proposed first age-based recommendation. We are putting this up because based on the majority of work group members, they had put this forward as what we should be discussing and voting on at ACIP. We would first like to ask if there is a motion for this particular age-based recommendation, and I promise we will come back and close the loop on the other conversation that happened earlier.
This is Dr. Bell.
Yep, it's Dr. Bell.
Sorry.
This is Amanda. I just want to let everybody know that I just want to remind everybody that after the age-based recommendation, there is a second proposal on the table for the risk-based recommendation, which will come after. So I don't want people to think that this is the only motion that we're asking for.
Okay, Dr. Bell.
I will make the proposed motion.
Thank you. So we have a motion on the table. Would anyone like to second that motion? Dr. Lair.
I'd like to second that motion. I have a small process question. Are we supposed to be voting now or after public comment?
We will take a vote after public comment, but we want to make sure there is a motion on the table for that vote. So I have heard that it's moved and seconded that we adopt the recommendation language presented by the work group listed here on the slide, which is a proposed age-based recommendation, adults 65 years of age or older, who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV20 or PCV15. If PCV15 is used, this should be followed by a dose of PPSV23. Now, I want to, as a matter of process, want to confirm and ask if there are any additional motions that people would wish to make, such as an amendment to the current proposed recommendation. Dr. Talbot.
I would love to make an amendment. I would like to alter the current recommendation that is up to say adults 50 years of age or older.
And the remainder of the text remains the same, should receive either a pneumococcal PCV20 or PCV15.
Yes, thank you.
Is there a second for this particular amendment on the main motion? Ms. Bata.
Yes, I second that amendment to the proposed recommendation.
Okay. Dr. Alt, did you wish to make a comment?
Might be nice to have a brief review of Robert's Rules of Order about how we're going to approach this in your role as chair, Dr. Lee. That was what I was thinking.
Okay, thank you. I think the way we're going to approach this is as follows. So we have now an amendment that has been put on the table and seconded that the proposed age-based recommendation be shifted to adults 50 years of age or older who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive either a PCV20 or PCV15. Again, if PCV15 is used, it should be followed by a dose of PPSV23. Two things. One is after the public comment, we will take a vote first on the amendment and whether or not there is agreement. We will ask ACIP members to vote on whether that language should be changed. And if not, then it would go back to the main motion, where we would go back to what is listed up here, which is adults 65 years of age or older. After that, we will then move on to the next vote. Are there any questions or clarification? And I'll turn to Dr. Cohn and Dr. Wharton to make sure that I am doing this appropriately. Is there any further discussion people would like to have in the moment regarding the current proposed main motion or the amendment? Okay. With that, we'll move on to the next proposed recommendation. I'm getting clarification from Dr. Cohn. This is good. Where per procedure, she would like us to vote on the amendment now so we can finalize the proposed recommendation for the full vote. So now I will take a look and just again request, is there any discussion that's needed before people vote on the amendment to the current proposed age-based recommendation? Okay, I am not seeing any hands raised. So I hope it's clear what the amendment is to the proposed age-based recommendation. It is listed there, changing 65 years to 50 years. And what I will do is I will ask individual members to state your name if you have any conflict of interest and whether or not you vote yes or no on the amendment for the change to 50 years. So I will start with Dr. Daly.
Daly, no. No conflicts.
Thank you. Dr. Cotton. Dr. Cotton.
Yes, Camille Cotton, I vote no to the amendment.
Thank you.
No conflicts.
Thank you. So name, no conflicts, and vote on the change to the amendment. Dr. Lair.
Lair, no conflict. I vote no to the amendment.
Thank you. Dr. Long.
Long, no conflict, no to the amendment.
Thank you. Ms. McNally. Ms. McNally, I think we can't hear you yet. We'll come back to Ms. McNally. Dr. Paling.
Dr. Lee, sorry.
Oh, great. Okay, go ahead, Ms. McNally.
McNally, no conflict.
Thank you. Dr. Paling.
Paling, no conflicts, no.
Thank you. Dr. Sanchez.
Sanchez, no conflict, and no to the amendment.
Thank you. Dr. Talbot.
Talbot, no conflict, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
Bata, no conflicts, yes.
Thank you. Dr. Bell.
Bell, Bell, no conflicts, no to the amendment.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, no to the amendment.
Thank you. Dr. Chen.
Chen, no conflicts, no.
Thank you. Dr. Sineas.
Sineas, no conflict, yes.
Oh, sorry. I was muted the entire time. Okay. I just read out the entire proposed risk-based recommendation, clarifying that adults 19 years of age or older with certain underlying medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV 20 or 15. And if PCV 15 is used, this should be followed by a dose. Yes.
We didn't hear your vote nor the final result.
Oh my goodness. Okay, I was muted for far longer. Thank you, Dr. Schaffner. I had said Lee, no conflicts, no. The final tally was 4 yeses, 11 noes. The amendment does not pass. And so we are back to the age-based recommendation listed here. Any questions? This will get voted on after the public comment period as the original motion that was put forward and seconded. Now we will move on to the risk-based recommendation. Sorry to keep everybody in suspense. All right. So based on the age-based recommendation that was shown on the prior slide, we will focus on the risk-based recommendation, which is the adults aged 19 years and older. I will not reread this. It's listed on here, and by implication from the prior age-based vote, it will be adults aged 19 years to 64 years of age with certain underlying medical conditions or other risk factors. And now I will ask for a motion for this proposed risk-based recommendation on the table. Ms. McNally.
McNally, no conflict, yes.
I think we're asking for a motion for the proposed risk-based recommendation on the table right now. Would you like to make a motion?
Yes, actually, I move that we accept the language as proposed on this slide.
Thank you. Dr. Kimberlin, do you have a question or comment?
It can wait till after a second.
Okay, thank you. Dr. Daly, would you like to make a second?
Yeah, I second the proposed language here. Thanks.
Thank you. It's been moved and seconded that the proposed risk-based recommendation as described on this particular slide move forward to a vote after the public comment. And now I'm happy to take any questions or discussion. So Dr. Kimberlin, back to you.
Just a very basic question. The committee can vote in favor of both
the age-based recommendation and the risk-based recommendation. This is not one or the other. This can be both if both are affirmed. Is that accurate?
That's correct. So there is an age-based recommendation for 65 and over on the table, and then there is a risk-based recommendation for essentially 19 to 64 years of age. Dr. Long.
Yes, Dr. Lee, because we don't know how those votes will go and we potentially could split on what vaccines we're talking about, I would suggest that this recommendation specifically say adults age 19 through 64 rather than and older.
Hi,
So
Dr.
Clarification.
Dr. Long, thank you for your comment. So the reason why the language currently says 19 years of age and older is because potentially somebody who's age 64 can receive this vaccine, and then if the age-based recommendation passes, then we just wanted to avoid confusion that at the time the person reaches age 65, they'll receive the vaccine again based on the age-based recommendation. So that's why it's currently written as is, and we're hoping to provide further clarity in the clinical guidance that will accompany. Thank you.
But what if Dr. Kobayashi and Dr. Palin, what if we get to the vote and it doesn't pass, or somebody puts an amendment that it not include both vaccines, or one or the other not include both vaccines, since both clearly talk about people who have not previously received vaccine, I don't see the problem with 19 to 64, which would seem to clarify that this is a different recommendation than the age-based.
Thank you.
It's an age-based by risk. You do what you think is the cleanest way to do it. It's just an observation of the language.
Yes, thank you for your comment, Dr. Long. We'll make that clarification.
Any other comments or discussion?
Yeah, this is Dr. Brooks. In looking at these underlying conditions, medical conditions, there are significant ones left out, and I'm sure that there's data for it, but hypertension and obesity are not listed, which would be a large proportion of the population that I think might benefit from getting vaccinated at a younger age. And maybe the internists have a couple more conditions that are not here, but other than diabetes, the other ones are relatively specific. I mean, chronic heart, lung, liver, but I just would like some discussion regarding the underlying conditions that qualify.
Hi, Dr. Brooks. This is Dr. Kobayashi again. Thank you very much for your comment. So we have received or had discussions about revisiting the underlying conditions. The current conditions that are listed here are exactly the same as what we currently have under the current risk-based recommendations. And then at this point, we focused on recommending these new vaccines. And then in the future, because there are other conditions that we have received suggestions for review or consideration, if needed, we're happy to revisit that conditions.
Okay, and that actually is okay with me if this aligns directly with the prior underlying medical conditions, because there's a presumption there was research and data presented that those were the relevant ones, that these are the relevant ones. Thank you.
Thank you, Dr. Brooks. And I think that's also in line with prior comment by Dr. Cotton around just clarifying definitions around these high-risk populations. Ms. Bata.
Yes, just a clarification. At the 19 years of age or older, we will be seeing people that received pneumococcal conjugate vaccine in infancy. would we, will there be clinical guidance about those who received vaccination, or should they, if they haven't received vaccination, from 19 on? That could be confusing.
Thank you very much for the comment. This is Dr. Kobayashi again. So yes, there will be clinical guidance, and the initial plan was to show the proposal at this meeting, but we realized that the work group requires further discussion on that guidance language, but that will be accompanying the new recommendation. Thank you.
Thank you. Dr. Long.
I think I also remember, and Dr. Kobayashi and Dr. Paling will correct me if I'm wrong. Regarding obesity and hypertension, there are not data that we have that those are increased risks for invasive pneumococcal disease. And that, along with having harmony of the recommendations with the previous language in comparison with the current recommendations, I think we did not have data suggesting that there were other risk groups that we had not considered. Please correct me if I'm wrong on that.
Hi, Dr. Long. This is Dr. Kobayashi. So we started looking at the risk associated with obesity, but we didn't have time to, take a deeper dive into whether certain conditions warrant consideration as part of the risk-based recommendation. And I think it warrants additional time and consideration to considering that there are other suggestions about clarifying or adding other conditions or groups. So if warranted, we'd be happy to review those data in more depth. Thank you.
Thank you. Ms. Bata, did you have another comment?
Oh, I'm sorry, I forgot to put my hand down.
Thank you. I'm not seeing any other hands raised in the moment. Oh, here we go. Dr. Hoag.
I just wanted to ask, Michael Hoag, American Pharmacists Association. I just wanted to ask for some clarity. I recognize that the implementation recommendations from CDC would come with the publication, but in the previous recommendation, the interval for the dosing of PPSV following conjugate vaccine was clearly stated in the recommendation. Would there be value in the last sentence of saying if PCV 15 is used, this should be followed by a dose of PPSV 23 1 year or longer? Should the interval be placed here just for clarity and to help eliminate confusion? I just offer that as a suggestion.
Dr. Kobayashi, would you like to respond?
Yes, thank you for your comments. And yes, in the previous votes, I do think that the intervals were included. The work group did discuss the possibility of harmonizing the recommended intervals. And we have discussed, harmonizing it at least 8 weeks or at least 1 year. And based on the current discussions, the work group was leaning towards harmonizing at least 8 weeks, because that would give more flexibility for the clinicians, and then also will provide an opportunity for people with immunocompromising conditions to receive the second dose sooner rather than later. However, there are data suggesting that waiting longer, especially in immunocompetent adults, might induce a better immune response. So because of that, we are hoping to include that also as part of the clinical guidance with some clarity on who might benefit from certain intervals, but with the spirit of harmonization. Thank you.
Thank you.
Thank you. All right, with that, I think we will plan to close this session and recess for lunch. So we will plan to be back at 15 after the hour, where we'll resume discussion with the zoster vaccine session. Thank you, everyone.